the moderator is going to start the session with our first presenter. Thank you for your kind patience.
Dear all, welcome you all again. So we'll start with our first presentation from Dr. Fatima Karim. Her title of her presentation is WASH, Water Sanitation and Hygiene Situation Analysis in Selected Community Clinics in Bangladesh 2019. Dr. Fatima completed her graduation from Proipur Medical College in 2013. She joined Bangladesh Cadre Service in 2014 as a medical officer at Begumganj Upazila Health Complex of Noakhali district. She completed her master's in reproductive and child health in 2019 from Bangabandhu Sheikh Mujib Medical University. Currently, she is working as a medical officer in Coordination, Support and Innovation Center of Directorate General of Health Services. Over to you, Dr. Fatima Karim.
Thank you. Assalamu alaikum. A very good morning to you all and welcome you all to my presentation. I'm Dr. Fatima Karim, Medical Officer, Coordination, Support and Innovation Center from DGHS. My study is about water, sanitation and hygiene situation analysis in selected community clinics, Bangladesh 2019. In 1978, Bangladesh signed the Alma-Ata Declaration with a promise to ensure the health for all by 2000 through primary health care. Throughout the 2030 Sustainable Development Agenda, SDG6 prioritized WASH, water sanitation and hygiene to ensure availability and sustainable management of water and sanitation for all. Hence, every healthcare facility needs to apply attention to service delivery by giving more emphasis on the WASH situation. For this, we conducted our research to assess the present WASH situation of selected community clinics in Bangladesh, and it is our general objective. Here is the methods. A cross-sectional study was conducted in 30 randomly selected community clinics in Begumganj and Sonaimuri Upazila of the Noakhali district in Bangladesh. The sample was selected by convenient sampling technique. Here are the data collection process. The data were collected by the questionnaire from the healthcare providers, and the situation was observed with an observation checklist by recommended WHO UNICEF GMP service. For ethical consideration, we have official clearance for the protocol from the Institutional Review Board IRB of Bangabandhu Sheikh Mujib Medical University, and permission was taken from Plan Director of Management Information System and CBSC Community-Based Healthcare UHNFPO of Begumganj and Sonaimuri Upazila of Noakhali district, and also informed written consent was taken from the interviewer. Here are the results. In this section, we see the result section of the table shows that the WASH situation in the community clinics. We divided the WASH service in three different sections: basic service, limited service, and no service. For water, where water is available from an improved source on the premises such as tube oil, piped water, rainwater is basic service for water. And in our study, we find for sanitation, if improved sanitation are usable with at least one toilet dedicated to staff, one sex-separated toilet with menstrual hygiene, and at least one toilet accessible for people with limited mobility is the basic service of sanitation. And in our study, we find it 0. But the limited service is 93.3%, because here limited service means at least one improved facility is available, but not all requirements for the basic service are met. For hygiene service, the basic service means if water and soap or alcohol-based hand rub are available at points of care and within 5 meters of toilets for functional hand hygiene, it is called the basic service for the hygiene. And in our study, we found it 30%. In this section, we demonstrate the water source of the community clinic. In the community clinic, we found that 76.6%, 23 community clinics have water source from the tube well, and 20% community clinic have piped water collected by electric motor, and 10% collected rainwater. An improved water source within the 5 meter have only 60%. And improved water more than the 500 meter, which is limited service, is 3.3%. Here are the results of the sanitation facility in the community clinic. If we see the table, we see the latrine within the community clinic have two different kind of. One latrine, some clinic have one latrine and some clinic have two latrine. Here are functional are 18. Here 18 community clinics are functional, but among them 14 community clinics have one latrine. Others are two latrine. On the other hand, outside the community clinics, we found only 5 clinics are functional, but 2 community clinics have no latrine at all. Here we see the hygiene facility in the community clinic. Use of soap and hand washing system in clinic and the latrine. In the graph, we show that 40% clinic have soap or hand washing system for hand wash in their community clinic, and 60% have no soap and hand wash in their community clinic. In the second graph, we show that in latrine, we have 33.3% community clinic have soap and hand washing for hand wash, and 66.7% have no soap or hand wash system in their latrine. So, in conclusion, we can say that in our study, we found the scenario of the sanitation and hygiene was not satisfactory. And for this, it is evident that healthcare stakeholders need to ensure that all the healthcare facilities provide adequate wash arrangements through integrated collaborative partnerships. And also further study should need for wash analysis. Thank you all for your patience hearing.
Thank you very much, Dr. Fatima. I can see one question from Dr. Jafrin from IDCR. The question is, did you have any operational definition for basic, limited, and no services?
Yes, I have some operational definitions. For water service, it is when the water is available from an improved source on the premises, such as piped water, tube oil, rainwater, is basic service. And for water service is limited service. When we call the limited service, when it is the improved water service is within the 500 meter of the premises. And no service means there are no improved source in more than 500 meter. And for the sanitation, improved sanitation means usable within at least one toilet dedicated to staff, one sex-separated toilet with menstrual hygiene, and at least one toilet accessible for people with limited mobility is basic service for sanitation. And for sanitation, limited services means at least one improved sanitation facility available, but not all the requirement for the basic service that I said earlier are not met. And on the other hand, no service means there is no toilets in the community clinic or the premises or outside the premises. And for the hygiene facility, if water and soap or alcohol-based hand rub are available at points of care and within the 5 meters of toilet for functional hand hygiene, it is called basic service for the hand hygiene. And hand hygiene for limited service means functional hand hygiene facilities are available either at points of care or toilets, but not both. But no functional hand hygiene means either at points of care or toilets means no hygiene facility. Thank you.
Thank you, Dr. Fatima. Another question from Dr. Shudev. What was your intervention, or whether any intervention has been planned after this study? Over to you, Dr. Fatima.
There was no intervention in my study, but I would like to go for some intervention in some community clinic to see the improvement of if I have any intervention, then what is the improvement for future. But in my study, there is no intervention.
Okay, thank you very much. I think another question from Dr. Jafrin, how the functionality of the latrine was defined.
The functionality of the latrine defined means it includes wet sanitation technology such as flush or pour flush toilets connecting to swag, septic tanks, pit latrines, and dry sanitation technology such as slab connecting dry pit latrines and composting toilets. It means the improved sanitation facility.
Thank you very much. Any additional question from the audience? Like we have still have 2 minutes more. If not, probably we can go to the next presentation. Thank you very much, Dr. Fatima Karim Rupa.
Thank you, sir.
So our next presenter, Dr. Mohammad Samiur Rahman Chaudhuri. The title of his presentation is Evaluation of Community-Based Surveillance in the Rohingya Refugee Camps in Cox's Bazar, Bangladesh 2019. Dr. Samiur graduated from Bangladesh Medical College and Hospital in 2013. He has completed his master's with epidemiology major from North-South University in 2016. Currently, he is pursuing MSc in Health Economics from University of Dhaka. He worked as a research associate in Department of Public Health, North-South University in 2014 to 2017. He has been working as an epidemiology activity manager in Medicine Sans Frontiers, MSF, since 2018. Over to you, Dr. Mohammad Samiur Rahman Chaudhuri.
So, Assalamu alaikum. Can you please share my presentation in the screen? Or I can continue myself. Hello, can you hear me?
Yeah, you continue, and I am requesting our technical team to share the presentation, please. Yeah.
Sure.
Go ahead.
Okay. I'm Dr. Sabi, working as an epidemiology activity manager in Cox's Bazar, Bangladesh. Our research title was Evaluation of Community-Based Surveillance in the Rohingya Refugee Camps in Cox's Bazar, Bangladesh. So, if I talk about some background about the context, so as community-based. So the CBS mechanism was mainly administered by Rohingya community health volunteers, just to make sure in this point that we selected Rohingya volunteers to make our study or method or surveillance system is more adequate, more trustworthy, to go close to the community people. Then the aim of the surveillance activity was mainly to detect and timely response of the suspected epidemic-prone diseases, and then especially monitor the community-based surveillance closely, including the indicators of birth, neonatal deaths, and other relevant indicators regarding Watson or WASH related issues. And then we also looked about the how many birth rate, or whether the pregnant women, they are willing to go to the health facilities for their delivery, and closely monitor the population movement. This context or this refugee area, it's always very fragile and moving from one camp to another camp due to some issues what happening in the area. So especially regarding the disease, we have looked about the acute flaccid paralysis, acute watery diarrhea, acute jaundice syndrome, diphtheria, measles, meningitis, dengue, and what I said earlier that about Watson issues, birth-related issues, and the mortality thing. If we talk about the method, then we can start this surveillance data have been collected in multidisciplinary approach. Different departments within our organization were working as a team to inform their decision and in the programmatic approach. In the aspect of clinic-based surveillance, we have two health facilities. It's both are the one is a secondary level hospital and another one is the primary health center. So in the community-based approach, that was, as I said earlier, that was very exhaustive. That means house to house actively visited by Rohingya volunteers. In our catchment area was total 13 camps out of total 32 camps of the Rohingya camps. So we had 140 surveillance workers, each household visited monthly. So especially we divided households by odd and even number. So each household has an equal household number. The first 2 weeks, we selected our surveillance cycle out of total duration of 4 weeks. We covered for all even household numbers, and the next 2 weeks we have covered all odd household numbers. This mechanism allows for early outbreak detection because even during the odd number household visits, the surveillance worker asked to the even number visits if they have, household members, they have any similar signs and symptoms who are suffering in their households. And we found that they are always willing to talk within their community members. So that's why it's another issue that, not actually it's an issue, it's our achievement that we have selected volunteers to get the proper information or to close more to the community level. Then if we discuss about the method and everything, so CBS data is used by the especially TBA, traditional birth assistant, in surveillance team reported pregnant women in a household. Then in the next morning, TBA, our MSF TBA will visit that household to verify that case. If it's necessary, then TBA is referred to the nearest health facilities. It's not necessary that we are always referring to go to the MSF hospital, because in the community level there are a lot of hospitals, then health posts running by different organizations. Our main target is to ensure that the community people are taking care from the health facilities. Health promotion activities, like our surveillance team, we found that something is going interesting or new disease in the community level. We used to share this information to our health promotion team immediately so that they can monitor and they can provide the preventive approaches like health promotion messages to the community level so that they can be more aware to prevent that disease. aiming to respond that outbreak-prone diseases as soon as possible. Active case findings we have done, and contact tracing as well. Insist of referral to the nearest health facilities. And we have another department or team like medical response team. They also verified that suspected cases if we found from the community level about acute flaccid paralysis, meningitis, and we also did verbal autopsies, because these informations are pretty technical and medically defined. So we used our medical team that was comprised of one doctor, one medical assistant, and one nurse. Additionally, one Rohingya volunteers as a team. And we have another team which was also part of our response. It's a Watson or water and sanitation team. They usually respond acute watery diarrhea, acute jaundice syndrome, and skin diseases. The main indicators of Watson team of that, the maintenance of hand pumps, increase access the chlorinated water in the facility, in the community level, then water storage containers, whether they are available in the community level, and establish hand washing points with water and soap. So actually, for the establishment of hand washing points with water and soap, MSF didn't put or establish any hand washing point. So as it was one of the indicators, so we tried to look at whether it's available close to the households. If it's not, we usually advocate to the Wash Health focal point for the community, for the specific camps, so that they can feel that this is necessary and they can establish one hand washing point, including water and soap available. And also we dislodge the latrine and maintenance of the latrines. And if we found that this is outside the catchment area, if we found any latrines are not usable or not functioning, we also push to the focal point that this is necessary to maintain it. Additionally, our midwives, they are also they have also worked for the combined with traditional birth assistance.
Samir, sorry for
Yes.
interrupting. We don't have any time to continue this one.
Okay.
Yeah, sorry. Sincere apologies for that. I think we can take only one question for the sake of time. The question for you: did you detect any outbreak from this surveillance? Asked by Dr. Jeffrey.
Yes. So in 2019, we have found total 21 RDT positive cholera cases. Out of that, two cases was RDT positive cholera and also culture positive, which was tested by ICDDRB. And additionally, we found measles outbreak within two catchment area or camp. So MSF is not able to or allowed to declare an outbreak. So all the outbreak have been declared by collaboration with the WHO and Ministry of Health. So usually we once we found this kind of new diseases or if we found that these things is going beyond the threshold level, then immediately we used to share with the WHO, and WHO, they can start their response. And they said that, yes, this is an outbreak with the Ministry of Health. Hello?
Yeah, thank you very much, Dr. Samir.
Thank you so much. Thank you, sir.
So our next presenter is Dr. Prabir Chandra Roy. The title of his presentation is The Prevalence of Tuberculosis Disease Among the Knit Garments Workers. Dr. Roy is a public health expert and currently working at National AIDS STD program of DHS as the monitoring coordinator. Before that, he worked in different public health programs since 2015. Dr. Prabir Chandra Roy, over to you.
Yes, thank you very much. Can you hear me, please? Can you hear me, please?
Yeah, we can hear you. Just
Okay,
go to the
thanks.
presenter mode for your presentation, please.
Okay, thanks to moderator and honorable audience. I'm Dr. Prabir Chandra Roy, working at DGHS, and going to represent my study report, the prevalence of tuberculosis disease among the net garment worker. Next. We know Bangladesh knitwear sector is the largest exporting industry in Bangladesh and contributes to the Bangladesh economy. Huge population of the country. We know more than 40 lakhs workers are working in this sector, and among them 80% are women. Although they contribute to the Bangladesh economy, but their lifestyle, their dietary pattern, their educational level, and socio-economic status are very poor, and they live below the poverty line. And most of the workers are facing different health problems, and tuberculosis is one of them. We know Bangladesh is the more prevalent and in the list of 30 high TB burden countries in the world, and Bangladesh ranks 6th in position among the high TB burden countries, and till now it is a public health issue. And most vulnerable groups in Bangladesh are slum people, garment workers, etc. And our government has taken different initiatives in restrictive manner through the DOTS concept with free of cost with testing facilities such as X-ray, gene expert in Upazila and Jilla level facilities, and medication facility also. Next. General objective was to assess the burden of tuberculosis disease among the net garments worker, and these are the specific objective to assess the prevalence of tuberculosis disease and to describe the socio-economic status and to describe the distribution of pulmonary and extrapulmonary tuberculosis among the net garments worker, to explain the tuberculosis distribution by socio-demographic factors in net garments workers. Next. The study design, this is a cross-sectional study who's quantified the distribution of TB among the net garments workers and conducted from January 2000 to 2020 to December 2020 at small and large net garments factories at basic Nanganj. Data was collected with purposive sampling technique from the 1,450 workers. Next. Data collection technique was to face-to-face interview, in-depth interview, and the data was collected with the semi-structured questionnaire. As per BKMA database information, there are small and large 300 net garments factories in this industrial hub. From these factories, 50 factories were included by purposive sampling method for data collection, and the workers were selected by national algorithm who are suffering from 2 weeks cough, fever, loss of appetite, such as weight loss, and cervical and axillary lymph node swelling. Following selection, detailed history was taken and referred to the diagnostic center for physical examination for X-ray and following the gene expert test. Next. This is the results section. This pie diagram shows the distribution of TB cases among the male and female workers, and most of the cases, 54% are male. Next. This diagram shows, we can see that this bar diagram, the level of education of the respondents, most of the respondents, 37.1% were only able to sign, and 23.4% were illiterate, and 31.3% were primary school passed, and 7.3% were SSC passed. Next. Pie diagram shows the distribution of the nature of the work of the business worker, while most of the workers, 47%, are working in sewing and linking unit. This is the most important unit for the net garments worker in net factories, and least number of workers in raw material dealing unit. These are the nature of work of workers. Next. The table shows the distribution of the socio-demographic characteristics of the net garments worker and suspected of having the TB disease, and seen that significant number of workers are found in poor monthly income, more than 8 hours working in their workplace, and housing more than 5 workers at one place within family residential areas, and most of male workers are in active smoking. Next. The diagram shows the distribution of different categories of tuberculosis disease among the male and female patients, and male patients are more than the female in each category of tuberculosis disease. Most of the cases are found in extrapulmonary TB cases, and least cases are found in pre-treatment relapse cases, TB cases. Next. The table shows the distribution of different categories of tuberculosis disease, and significant number of patients we see that was seen in the extrapulmonary cases, and least number of pre-treatment relapse TB cases, 19% was seen. Next. And this table shows the age segregation wise TB patients, and most of the cases 30% are found in 25 to 34 years of age group. And this age group workers are seen more in the factories. Least cases are found in the above 65 years age group. It is seen that the number of patients has been decreasing gradually with the increasing age. Next. Next. Next, hello. Next. Next slide, sorry, next slide.
I think we are having some technical problems. Yeah, Dr. Prabir, they are getting, yeah.
Next slide, please. Next slide, please.
Dr. Prabir, please continue. Yeah.
Next slide. Next slide. Okay, thank you. And this diagram shows the distribution of TB case notification based on the age and sex of the respondents, and number of cases in male and female patients was seen gradually decreasing with increasing age of the respondents. As aged people are working less in the factories, no significant difference was found between the male and female workers having the pulmonary and extrapulmonary TB cases. But in both cases, female are more prone to develop TB than that of male. Next. And discussion. In this study, we have seen that the TB prevalence was higher in male than that of female, and 54% are male and 46% are female, and 306 patients are diagnosed among the 106,632 knit garments workers, where the overall prevalence of TB cases among the workers was estimated as 287 per 1 lakh. And the prevalence was the highest in the 25 to 34 years of the age group. On the other hand, recently prevalence survey, we have seen that in that area, the higher prevalence among the urban areas and in urban industrialized areas. Next. Next, please. And also say, sorry, next, please. Next slide, please. Next, sorry. Sorry, next slide. Please, can you hear me?
Yeah, I think we can hear you. Just probably we are trying to show you the slide.
Okay. And also seen in different studies that high prevalence of TB in slum areas is 253 per 1 lakh population, in addition to high prevalence of malnutrition among the detected cases. TB prevalence is higher among the R&D sectors and slum population due to poor nutritional status, unhygienic lifestyle, and poor economic status. Finally, we can say that the prevalence of TB cases among the need garments workers is higher than that of general population. And we see in the studies that in China, India, and Ethiopia, among the R&D sectors are more prevalent to that of Bangladesh. Next. We can conclude that the TB among the need garments workers is a more alarming health issue than among the general population of Bangladesh. To sustain and increase the growth of economy in this sector, more intervention should be implemented in this sector. Next. Thank you very much for the questions sharing. That's all for my presentation.
Thank you very much, Dr. Probir. Nice presentation. I can see a question from Dr. Jaffreen, IDCR. Did number of person per room was calculated considering the size of the room? Did you see any relation with the number of the person working in a room and TB prevalence? Over to you, Dr. Probir.
Because they are their accommodation in a crowded places, and they work in a crowded workplace, and housing status is very crowded, and more than housing more than 5 workers at one places within family residential areas. And this is the relationship, I think, this is the relationship between tuberculosis and the housing status.
Thank you. Did you calculated did you conducted an analysis for any risk of crowding in a housing or in their working places?
But it is a cross-sectional study. No interrelation or association or is not seen.
Okay, thank you. I have a question. Like you mentioned in your methodology that you conducted in-depth interview. So you probably didn't present that result of an in-depth interview. What have you found through that in-depth interview?
Generally, their lifestyle, their dietary pattern, their occupational status, economic status are very poor. We have found in this sector, in this study, and we have organizing FGD and find that these are the real fact for the TB cases.
Okay, thank you, Dr. Prabir. Any presenter? Um, our next presentation is from Lieutenant Colonel Dr. Nazmul Huda Khan. The title of his presentation is Pre- and Post-Displacement Factors Revealed Amongst the Forcibly Displaced Myanmar Nationals, that is FDMNs in Bangladesh. Dr. Lieutenant Colonel Nazmul Huda Khan completed his MPhil and MPH. He is now working as an assistant director in Kurmitola General Hospital. Dr. Nazmul, over to you.
Respected moderator, distinguished audience, Assalamu alaikum and very good afternoon. The picture denotes what I'm going to present today. Welcome. My topic of my today's presentation is pre- and post-displacement factors revealed amongst the forcibly displaced Myanmar nationals in Bangladesh, as already stated by our respected moderator. In my 10 minutes or so, I will highlight and unfold my presentation in the following headlines flashed on the screen. Ladies and gentlemen, you perhaps know for millions of years mankind has been on the move, mainly for two reasons: proactively to search a new opportunity, new horizons or conquest, and reactively away from conflict, human rights violations, poverty, or (2017). They have since been in any other country in the world. And since 25 August 2017, more than 0.5 million Myanmar nationals have been forcibly displaced to Bangladesh. And now it's total 1 million. And this year, due to war, conflict, human rights violation, poverty, or repression. I term in my study is all pre- and post-displacement factors. That was my concern of this study. These are some pictorials which I have taken during my data collections. This is all from the Rohingya camp, Ukia, and Balukali. This is a simple descriptive cross-sectional study. My study population was, as you know, forcibly displaced Myanmar nationals. Locally, we call it Rohingya, fled to Bangladesh from 25 August 2017 onward. And there was a huge number of population there, so I followed a convenient method of non-probability sampling technique, and it was 248 respondents I selected from 8 blocks of 2 camps. And I collected data through face-to-face interview using Harvard Trauma Questionnaire that is revised. And definitely I used SPSS program 20 version to manage and analyze the data. So let's have a look on the result. Among my respondents, maximum is over 50%, 51% was female, and the maximum 32% was young, were 20 to 29 years of age, and maximum other 50% were from 30 to 59%. And very surprising that 79% of the respondents were illiterate, only 2% having secondary educations, and 19% primary. And regarding the occupation, farming was the highest and among others, and housewife, small business, day labor, etc., among others. And terribly, 66% had only about $60 income a month. And but having 2% were having 2 to 6, but 42%, almost close to 50%, had got 7 to 11 family members in a family. And maximum were from Mongodo district, that is close to Bangladesh, Cox's border, and other 70% from Butidong and Rathidong. And there, as per their statistics in Myanmar, about 72% had only kacha house. This is important. Predisplacement factors, what experience they have gathered during persecutions. You see in the screen, more than 90% were forced to hide. And terribly, about more than 16% had got experience of sexual abuse and rape. 30% torture, and about 16% had got experience of imprisonment, and about 26% had got experience of extortion or robbery. While possessors had lost their property, either destruction, and about 10% they lost their parents, spouse, child, friends, family members, while persecution are fleeing from Myanmar to Bangladesh. And about up to 50%, it is square marks is like murder of, they have witnessed murder or death of relatives due to violence, it is about 37.5%. Witness of torture of family members, relatives, like 84.7%. Witness to rape and sexual abuse, like 40%. Witness of dead bodies among my respondent was more than 80%. And about the state of satisfaction, you see I marked in the red color, more than about 80%. I should say some of them were 100%. They were satisfied with existing facilities, like state of toilet facilities camp, 77%. Availability of safe water at camp, more than 77%. Availability of food at camp, more than 88%. State of clothing and blanket at camp facilities, about close to 100%. And more commonly, importantly, health services, they were satisfied 100%, and safety or protection of yes, 100%. So let us compare with the other studies. In my study, I told you there is a printing mistake here. Marwa, he conducted a study in Swedish. Robert B. et al. Conducted a study in African country, Papua New Guinea. He has got only 27%. So you can estimate what is the literacy rate in doing this. And regarding the comparative analysis of conflict-related experience, I have studied already my status, but really he has conducted a study in 2016. His percentage was a bit higher. Also, Arsene Rejevic, he also got the result a bit higher because they have conducted their study in Myanmar side during the persecutions. Can you hear me, sir? Can you hear me, sir?
Yeah, we can hear you. Please go ahead.
Okay.
Although we have crossed the 10 minutes limitation. Please.
Okay, so just a few minutes, sir. Okay, then traumatic loss of properties. I have told already more than 80%. And Habib Echol, his team conducted a study. He has got the similar result in more than 85.9%. And witness of persecutions, I have got about 40 to 80% in various aspects. As time is short, so I'm going a bit faster. And Habib Echol and Habib and his team has got a bit higher in 2018 because he has conducted a study just during persecutions. And Kawai and his team in Papua New Guinea, he has got less about the witness of persecutions. And just this slide is very important. The state of satisfaction in camp in Bangladesh, it is close to 100%, all the parameters. But Kawai and his team, he has conducted a study in, among the refugees of Papua New Guinea. They have got satisfaction only about more than 10%. So this denotes the entertainment and good management of Bangladesh government. So I have got few limitations also, sir, language barriers and
Dr.
other things.
we have to finish it.
Sir, right, sir. Thank you.
Yeah, thank you very much. Thank you very much. This is a very good, important, and nice presentation. Any question from the audience, please? I like to thank all the presenters for their excellent job. And also, I want to take the opportunity to thank the team, moderation team, like Dr. Nusrat, Dr. Salehin, Dr. Jafreen, and Dr. Nobi, and all the audience.